from Montreal, and welcome to this week's CAEP COVID Town Hall. My name is Kirsten Johnson, and I practice emergency medicine at McGill University Hospitals in Montreal, and I'm also the incoming president of CAEP. So I should first start by apologizing for the change in today's town hall from yesterday to today. I mentioned on our last town hall that we would aim for Tuesday evenings, and unfortunately we only found out on Sunday evening that EMRAP scheduled their weekly broadcast on Tuesday this week, and we didn't want to compete since there is just so much important and good content that both events have to offer. So CAEP will aim to have a COVID town hall each week, and at this point it's probably best if you check the CAEP website for the specific day of the week going forward. In other CAEP news, the conference is now officially cancelled, and the notice has gone out to all of our members. The CAEP head office is working towards putting together what they can to virtually share with our membership. But in terms of a face-to-face meeting, the next one will be in Winnipeg in 2021, and I hope to see you there. Also, the publisher for CAEP's journal, CJAM, has decided that all new content related to COVID would be published open access at no charge to authors. So we are fast-tracking 4 COVID articles to make these available as quickly as possible. It's been an interesting 7 days since I moderated the last town hall. Here in Montreal, we are starting to see a sharp increase in cases, and we now have a pandemic ward at both hospitals where I work. My Monday morning this week started with a cardiac arrest in the pandemic ward. We followed the COVID protocol, which is not to start CPR before intubation. And it was like being in some strange slow motion movie, standing there, watching the patient and waiting for the intubation equipment and the team to come, not doing much more. It struck me and my team that this new way of coding a patient was counter to everything we had been taught and trained to do. And frankly, it was really tough. So I think that part of today's town hall that will cover the goals of care and ethics will definitely be very relevant to my own practice, and I'm sure it'll be the same for others. Another hot topic that we will cover today is personal protective equipment, or PPE. This topic will only be getting hotter in Quebec, where our Premier Legault announced today that we will officially run out of PPE in the next 3 to 4 days, but that we shouldn't worry because we will receive additional supplies from Toronto, care of Doug Ford. I'm certain our colleagues in Toronto are pleased to hear this news. We will also have a presentation that I hope will generate more discussion going forward on long-term care transfers. But to start, we will see how our colleagues in rural emergency departments are managing with the pandemic. So without further delay, I will introduce our speakers for this evening. Dr. Sean Moore is Chief of Emergency Services for Lake of the Woods District Hospital and Assistant Professor in the Department of Emergency Medicine for the Northern Ontario School of Medicine. He is also the Associate Medical Director for Orange Transport and Associate Medical Director for Critical Ontario. Dr. Merrill Pauls is a full professor in the Department of Emergency Medicine at the University of Manitoba and an emergency physician at the Health Sciences Centre. He is chair of the CAEP Bioethics Committee. Dr. David Mignon is the Associate Head of the Vancouver Acute Emergency Physicians Association and practices emergency medicine at the Vancouver General Hospital, BC Children's Hospital, UBC Urgent Care Centre, and is an ethicist for the Vancouver Coastal Health Region. Dr. Lori Mazurek, who is based in Toronto, has had over 25 years' experience as a critical care transport and emergency physician. She has expertise in PPE and conducts disaster exercises to inspire her interprofessional teams to find solutions, to healthcare shortages. She has been a consultant to the Ontario Ministry of Health, Public Health Agency of Canada, Global Affairs Canada, and the World Health Organization. And finally, Dr. Thomas Miller is an emergency physician at the Peterborough Regional Health Centre, where he was chief during the SARS epidemic and involved in H1N1 pandemic planning. He is vice president of the Professional Staff Association and assistant professor in the Department of Family Medicine. I would also like to remind folks that we have a chat function, and we welcome questions, comments, and constructive feedback. Christina Bova is moderating the chat, so please feel free to participate. So without further ado, I'll hand it over to Sean Moore, who is in Kenora. Sean?
Hi, thank you very much, Kristen. And you can step out and get some glass of water there. So yes, as she said in my introduction, I'll just bring up sharing my screen. I work in Kenora, Ontario, where we have no idea whether or not we have seen a case of COVID at this point because our turnaround times are so slow. We're seeing results from 2 weeks ago at this point. So I'm going to talk briefly about transport issues and some rural issues for everyone. I will say in my disclosure that I do own some shares of 3M stock, which has not done well for my RSP, so I'll be working longer as long as I make it through this pandemic. As far as an outline, I'm going to be talking about this from the perspective of a single physician rural ER where staffing issues are always present. I'll cover some advocacy and communication strategies, transport, which is a key area for success in rural areas. In addition, there's no shortage of order sets and pathways to be adapted. I'm going to bring up some of these topics because they were flagged as key issues in the CAEP and Society of Rural Physicians of Canada release that you see on the right-hand side. In that, there's a number of recommendations and some advice also for how to go about this in terms of rural advocacy, etc. So the flow of data is overwhelming at this time. So every day we seem to get a deluge of information. And I'm going to point you, for the rural folks out there, to try to take a consideration going on to the Rural Med listserv, which is from the Society of Rural Physicians of Canada and hosted by McGill. In addition to that, the CAEP website has some very valuable information, and it's being curated to just include the topics that everyone has in common and get into a little bit more detail. Those have changed on a daily basis, so please do check back at those regularly. In addition, there's the usual players from MCRIT, Rebel EM, and one of my personal favorites, EM Cases by Anton Hellman. These are just a wealth of information and have such useful data for all of us to watch, as well as learning tools. So some of the issues on staffing and capacity. If you're a rural doc, you know what's going on right now with staffing issues. Our locums have largely disappeared because of issues with quarantine. Sometimes when they're going across a border, I live in a border town, so our folks fly in from wherever to Winnipeg and then drive into Kenora, where they'll be stopped at the border and asked questions and to prove that they're an essential service. They are also being asked to quarantine for some length of time in many places. And these kinds of issues absolutely need to be resolved, where we ask people to self-monitor, et cetera, so that we don't share our COVID across borders and across different communities. The big thing that's lacking for us in the rural areas is that we can't do rapid testing of health staff. And with that, in Kenora, 5 of our medical staff who have the sniffles have been quarantined for 14 days, and a couple of them recently are off quarantine. But by the time we get our results back saying that they are COVID negative, they're already quarantined for 14 days. So it hasn't helped us whatsoever. So this is a huge issue, and it's one that we have to figure out in our rural areas. They are the physicians that are coming here for locums are largely seconded to their own community hospitals at this point, and the pool of locums is drying up. So a place like my shop, where we have approximately 20% of our coverage done through locum physicians, this can be a really, really big backbreaker for the rest of the folks in your town. So I also want to add that rural and community emergency medicine is going to be a key in our success as a country. And we have some amazing talent out in rural areas, and we have to try to provide for them and try to assist them to get these patients through this pandemic. So how do you get keep workforce in play? So in a smaller place, you'll often have people doing multiple generalist tasks. So 5 of our emergency doctors are also the 5 docs who do obstetrics, and 3 of them are the only ones in town who will do C-sections. So we try to support them, and if there are extra shifts that come up or that get canceled because people can't make it into the community because of cancellations of flights, etc., then we'll support those physicians in not taking extra shifts, but the rest of us are going to be pulling more and more shifts. You have to be ready for travel and quarantine and build that into your travel plans for all of your locums, et cetera. And a big thing right now, we have to get into the licensing issues and work those out immediately so that people can work across any jurisdictions, because as we've seen in most other countries, it tends to be somewhat regional in terms of the peaks of COVID so far. So we have to get rural testing at least for medical staff immediately, and we have to get this licensing taken care of. As far as triage and patient flow go, this is something that we all have to figure out in an emergency right now. We have to deal with the issue of hospital flow, or ER flow, and disposition decisions, and get those done before we start seeing lots and lots of patients. And I can speak to the Northwestern Ontario at this point. We have a large number of patients that are starting up, and again, it's somewhat regionalized and patchy at this point, but soon to fill in, where some very, very small hospitals have 3 admitted patients. Others have seen community spread. So this is something that has to be figured out in the coming days if you haven't already. So this is a hospital flow chart that was shared on our rural listserv site, and it's absolutely key that in whatever hospital you work in, that you develop these kinds of very, very quick flow diagrams showing what's going to happen if someone comes in through an ambulance bay, what if they're a walk-in, what if they're coming into maternity or oncology. And the New York experience is one that in the EM wrap with Swami last night, we saw that people were saying this is a COVID plus place, where the hospital becomes, I've got COVID and I'm delivering. I've got COVID and I'm an oncology patient. I've got COVID and I've broken my leg. And so we really have to get this down in terms of our ability to get people going the right way and to know what we're going to be doing for our PPE along the way. As far as ER flow goes, this is also shared from the CAEP website, where you have to, again, make very, very fast decisions and have everyone on the same page for getting our flow worked out ahead of time. A flow diagram up here on the top left is that's the one that's used in Australia, and the one on the right is what we're going to be using in our emergency department, as well as numerous people who have shared their resources. I think this is Dan Kolek's, right? In addition, some of the larger community hospitals, and not all hospitals in rural areas or communities are tiny. This is one from Lake Ridge, where they have, I believe, upwards of 50 some patients admitted at this time, and numerous vented patients. We try to find a simple algorithm to suggest that when we go to supportive respiratory therapies, this is a pathway like this is fairly simple. It's quick. It does require getting an ABG. So some of the smaller hospitals probably won't be doing these kinds of things, but for making a decision about when patients go home, go to a ward, etc., it's nice to have something concrete to work off for the meantime. This comes from Randy Wax in Southern Ontario. So I got this question to answer along the way. This comes from one of the CAEP members. Thank you for advocating for us regarding small ER. Comment on intubating a patient with overt respiratory failure and only direct laryngoscopy available, and prolonged wait for transport to a bigger site. So again, for that question, I assume that you probably don't have a negative pressure area, or perhaps only one. In my shop, we have 1 negative pressure room in our emergency department, and we had only 1 in our ICU. We now have 4 for all of the ICU beds, as well as a couple of a 3-bed cohort area in our operating room, where we've now got negative pressure available. But if you only have 1, we've got to get down to PPE has to be appropriate. A very quick response is ketamine rock. That we're going to go for very, very straightforward protocol for intubating patients. You want to have them absolutely flat, which means you're going to paralyze all of them and wait for the paralysis to work before making any intubations, because you don't want the cough in the face. We don't bag. We use closed circuit. We want to make sure that when we finally get them onto a vent, that if you have a vent or if you're bagging the patient, that we have a viral filter in place. And finally, if you are unable to get this is where you're going to be going for a crike relatively quickly. In addition, I would say some of the key points that people don't think of right away is making sure that all connections are taped and taped and taped until transport comes, and we can make sure that nothing gets disconnected so that we don't spew COVID all over the place. When the patient is finally left, if they do come to take your patient to a larger center, double bagging all your equipment and wiping down what you are while you're in enhanced PPE. The bottom line with this, though, is that PPE staff safety is the priority over patient care. The military way of looking at force protection so you can be alive to help the next day is absolutely the most important aspect of this. I'm going to move on to another topic, which is advocacy. You have to drive safety as a rural emergency physician. People are looking to you for your advocacy, and I would say forget normal chain of command at this time and the usual pathways. I talk to our member of provincial parliament, Rickford, on a daily basis. We text all of the time, and we speak in person once a day. Eric Malillo, who's our member of parliament, the same goes there. I talk to him and text him throughout the day, and they're working on things on our behalf. They really want to hear from you in rural areas as emergency physicians, because as constituents, they trust you and they know that you're on the front lines. The only thing I would suggest is making sure that you keep things simple when you're sending things forward to try to get proposals under control, not for them, but because they're going to be talking to a wide variety of different people, including staffers, et cetera, who may not understand some of it. And get out there. So I have, again, people, by virtue of being a physician in a small town, they're often very influential members of the community. And I started a blog for the first time about 3 weeks ago when this first started hitting Canada. And if you look at the page that I have there, this is from 2 days ago, and 17,000 people read this. And I've got 15,000 people in my community, so other people are seeing this from further away. We work with news people and photographers. I've got a guy who's basically out of work, but he's a journalist photographer, and he's taking pictures for all of our statements and things that we want to get out to our community members. Alan Drummond, Blair Bigham, these are people who have also really tried to get out there and do advocacy. It's super important because once it gets out there on the radio or newsprint, we can actually affect real change much faster. I'm going to be, as soon as we hang up from this call, I'm talking to someone from the Globe and Mail and trying to get something arranged about rural medicine and in COVID. And then 6:30 tomorrow morning, I'm interviewed on the Current. And this is not because I have any wish to be part of a spotlight in any way. This is actually a horror show for me, but I feel like it's our duty to really do this, because when I started doing this, people started listening in the community. So transport considerations. This is absolutely key, and we have to have transport at the local level, at the provincial level, and command center tables, and whatever tables you have in your hospital, you have to include transport. Our transport HEMS group, as well as our local land EMS, meet daily with the hospital to make sure that we have common protocols and procedures and flow pathways worked out. This is something that you absolutely have to have at every table, and you have to make sure that they're there. Even if you're not the guy that runs the system, you have to make sure that your local EMS are there at the table, someone to represent them so that they know how this goes. And by table, of course, I mean the same way that we're having this particular discussion. We have changed numerous things, including getting high flow into our emergency department. We've switched to iGels so that we can be consistent with what's being used on land. Those kinds of things that can happen very quickly when everyone's in the same room. So plan A in a rural hospital for a COVID patient is get them out. Plan B is the reality, which is care for them as long as you can and figure out who you can get to help you. And that said, telemedicine links can help a lot. And depending on where you are, these may be very robust, or they may be not so commonly known about. I would urge you for transport to keep all of the protocols simple and keep your connections very simple, as this is going to be hard for people to adapt. When we're talking about proning patients, whether they're awake or if they're intubated, proning seems to be very, very helpful. And in the experience in New York and other places, they're proning patients before intubating them for as long as they can tolerate things while they're awake and not intubated in prone positions for as long as they can tolerate it, and then switching them up 12 hours later if they can, again, if they don't have too much back pain, et cetera. So I got another question here from a rural area, which is what COVID-specific real-time support and resources will be available for acutely ill patients? This question came from NOSM-related hospital in Ontario, and I can answer this with the exception of Quebec. I can say that in your area, so in any of the Ontario, we would have telehealth available through what's called the RCCCR, which is the Regional Critical Care Response or Network, and then the VCC, Virtual Critical Care Network, in the Sudbury region in the northeast, excuse me. And anywhere else in Canada, this ROSE program that has been put in place by Don Burke and folks, you can download an app and you can telephone them, and basically you can telehealth network with any nursing station. It doesn't even have to be a physician, but physician or nursing station in North America, and they have reciprocal agreements where they'll provide that care to whoever is asking for it. So that's what I would say is make one of these well-established links. They are currently not able to practice in Quebec because of reciprocal payment agreements, and that's the only thing holding that up. So whoever is there from Quebec, Kristen, maybe you can figure that one out. Guidelines. Again, there's such a deluge of information. You have to figure out where to look. On the right-hand side here, the clinical flow charts and guidelines page on CAEP is very, very useful, including, again, here the COVID intake flow chart, history, physical exam, order sheets, the Surviving Sepsis campaign. We're trying to make sure that this website is curated so that it has the pertinent information that people can go to quickly and get to it. Of course, we have, again, ASAP, MCRIT, a lot of partners in this. And there's also the COVID information for Canadian physicians page on Facebook, which is a very valuable tool to see what people are doing. If you have any specific questions, they can often be there to help answer. Last slide in terms of guidelines and implementation. As much as you can, find the infographics that make it simple for everyone, and you can distribute this. People don't have infographic overload at this point. They just have data overload. So get yourself together in your rural emerge for a protected code blue, your ER flow, hospital flow sheets, sepsis management, COVID order sets, and I would suggest that you stay in touch with CAEP for these town halls as well as EM RAP for any of their information that they have going on, and you'll find that it's a whole lot easier to be on the same page as your whole department in your rural areas if you do so. So thank you very much for that opportunity. I hope I didn't talk too fast for everyone, but I wanted to leave time for my colleagues, and that's it for me.
Thank you, Sean. That was a really important topic that you covered for our colleagues who work in rural areas. We'll now change gear a little bit, and I will just put my screen up. For those who don't know me, my name is David Mignot. I'm an emergency physician in Vancouver, as introduced at the beginning, and I'm also an ethicist here in Vancouver. I have been involved at the provincial and local level at developing frameworks for distribution of critical care resources. That's been my full-time job, I would say, over the last 2 weeks. And today, me and Meryl will talk about the ethics topic. Sadly, right now, my slides are not loading up. Should take a second. There we go. I think we should see them now. Somebody can give me a thumbs up maybe to confirm that. Perfect. Thank you very much. So we'll talk specifically about pandemic ethics and the ethical consideration for resource allocation during COVID-19. The topics that I will cover today, more specifically, is we'll talk about public health ethics and how it's different than our usual clinical ethics. We'll talk a little bit about resource allocation, about triage in a pandemic, and then access to care and possible exclusion criteria that we could use if we reach a point where our resources are really, really, really short. So to contextualize a pandemic in ethics, we have to understand that we have to change our perspective about how we look at how we deliver medical care in an ethical way. So there's your traditional approach of clinical ethics, which values the rights of the individuals and their freedoms. And then there's the values of public health ethics that are similar, but really have a different focus because they look at promoting the benefit of the entire population. So we have a list on the screen here of common public health ethics values such as respect, the harm principle, fairness, meaning we treat everybody the same way and we really don't have a social judgment, consistency, least coercive and restrictive means. So that's a good example about the nuance between social isolation and a lockdown where people are forced to be home. So if the principle of a social isolation is enough, then we want to be as least coercive as possible and as least restrictive as possible. We want to work together, so breaking down barriers between collaboration between health authorities or different regions of a province, that's really important. There's the reciprocity value, and I think this is really important in the context of PPE, and we'll talk about this a bit later, but how as healthcare workers, we kind of put our life on the line a little bit more than other people. So there's a value in public health ethics that we deserve a reciprocal benefit and to be protected appropriately, and that's the role of PPE, for example. Proportional, so our actions in the public space need to be proportional, and then we need to be flexible because, as you noticed, I'm sure, things change almost every day, and procedural justice, we try to be systematic all the time. So we need to balance our ethical priorities, and I kind of said it already, between the individual rights and freedom, that's our traditional clinical ethics, and attempt to satisfy the needs of the broader public, and that's the public health ethics. And really, that's where we end up sometimes at a different place, and we provide care in a different way. So what does this mean when we talk about resource allocation? First, it's really important. Often we hear in the news distribution of ventilators. It actually goes well beyond ventilators, and I think we alluded to that about the resources in rural communities earlier. You may have as many ventilators as you want, but if you don't have the staff to provide the care, you're not going to provide the ventilators either. So it's really important to think about resource allocation, about all the resources that are necessary to provide the care that's required. So we should really aim at maximizing the effective use of scarce resources, and that includes the critical care resources, PPEs, human resources, and others. When we use public health values, we really look at the most amount of healthy life years, because some people feel we should talk about age, but it's not quite what we're looking at. Because somebody, a 50-year-old who's really healthy and a 40-year-old who's not really healthy would not be seen in isolation because of their age. You have to look at the entire context, and the way you contextualize that is to look at the healthy life years moving forward. The needs of the community in the pandemic really may outweigh the benefits of the individual, which may lead us to provide care in a substandard way. So we don't provide the usual standard of care. So when we increase the intensity of the resource allocation, then we think about the notion of triage. And I think most of us, we spend a lot of time learning about, disaster medicine, but pandemic is similar but different, because the healthcare demand will behave differently than during a single event that is a disaster event. So it's really important to take a step back and look at the system as an entire machine that functions in terms of tolerating the surge capacity that will come its way. And we know that when we talk about flattening the curve, and we've heard about that a lot, that's what we're trying to say. We want to minimize the amount of surge that will come towards the healthcare system and decrease the demand in critical care resources. So we have to put mitigating measures to do that, and sometimes we have to put extraordinary measures. Everywhere we'll have a different approach to this. Different at a provincial level and also at the federal level, but because healthcare is mostly managed provincially, there are groups of people that are working in the background preparing frameworks and policies and guidelines. Right now, it may not be communicated yet to the entire healthcare system or to the healthcare providers, but it's happening. First-hand knowledge that it's happening in Ontario, it's happening in BC and Alberta. There's a lot of people in the background trying to prepare these documents. It's really important because we want to be as informed as possible. We want to involve the people that are important, the important stakeholders. We want to be system-focused, reasonable, and objective. And we want to be transparent as much as possible. But we want to deliver something that is somewhat polished so we can actually start working and preparing for what's to come within the next few days. It's important to establish a collaborative decision framework because it's very different to be told by an outside entity what to do in terms of resource allocation. If the guideline tells us you have to do X and Y, but it's not in our practice to do that, this is a very big shift. So we actually have to make sure that we collaborate into implementing these frameworks and policies and shift a little bit how we deliver care usually. But just to give a general idea of what we've been working on is pandemic emergency triage is a little bit like disaster medicine. We divide it in different categories, and we try to categorize patients. Either they have, it's in here I put them in color, but there's different ways of doing this. But in blue, if it's poor expected outcomes, even in life-saving resource are used. So these people will not benefit from critical care. In red is the people that will most likely benefit from critical care. In yellow is the people that may benefit from critical care. And the difference is important here because high likelihood versus may benefit is really different when you're really short in resources. And the green is for the people that do not have really a need for critical care at this point. So how do we approach exclusion criteria? Well, clinical judgment should always supplement exclusion criteria. But in general, exclusion criteria have traditionally fallen under two categories. So it's either the criteria that indicate a low probability of surviving an acute illness, or criteria that indicate a low probability of surviving more than a few months, regardless of the acute episode of critical illness. So with that in mind, what we've been doing is to try, or like what your leaders are probably hopefully trying to do, is to develop criteria that will allow to execute that. A general idea that has been discussed across the country between our group is that we will define surge levels in terms of what's the prediction or the predicted mortality for a patient. So in a minor surge level criteria, we will exclude people that have 80% predicted mortality. In a moderate surge criteria, 50% predicted mortality. In a major surge criteria, 30% predicted mortality. And if we end up And after that, we end up in a place where we're really in a pandemic emergency triage. This is just an idea. This is not necessarily what's going to happen in your jurisdiction. Just make sure that you seek you reach out to your leaders to get some guidance. So to give a concrete example of that, being a severe burn, for example, for us, if they have two of the following criteria, either more than 60-year-old with age more than 60, total body surface area more than 40% or inhalation injury. So if they have these two of these three, then they would fall in a category that their predicted mortality is so high that allowing them to have access to critical care may not be valuable in a pandemic emergency triage situation. So there are many more criteria like this that has been worked on by critical care physicians across the country. Hopefully, that will be distributed at large, hopefully very soon. Just a last plug about ethics here. There are indefensible criteria, things like age, stage of life, mental ability, physical ability, or disability should not be used in isolation as an allocation criteria. The moral worth, value, and dignity of all persons are equal regardless of these criteria. So it's really important that we consider these criteria, but they have to be contextualized with objective clinical features such as like comorbidities, for example. That is all I have to say for now. Keep yourself posted because I'm sure there will be more guidance from your authorities within the near future. And if not, you should seek help from hopefully your critical care colleagues for resources, or if you have access to ethics services, please do so. I will now pass the torch to Meryl. Thank you.
Excellent. Thank you so much, David, for that. I'll just quickly move right along. I will start my sharing. Let me just make sure that we've got what we need to. All right, hopefully everybody can see that. I just want to say again, thank you so much to people for submitting questions. We don't specifically address them in our presentations, but our topics were chosen based on those questions, and we're for sure happy to follow up with any questions that might come in through the chat. So for these next few minutes, I'm going to talk about the difficult balance between our duty to care for patients and the need to stay safe. And so like most of you, I'm turning the news on every day, and I'm seeing these heroic stories of doctors providing incredible care, but often it's coming at a significant personal price at the high risk that they're suffering. And it makes me wonder, what level of risk is okay, and when are we asking too much? Should this be a personal decision, an institutional decision, or a professional one? What responsibility do our institutions have to provide for our safety? And how can we reasonably and rationally plan for when PPE stocks run low or actually run out? And for sure, in my conversations with emerge docs across the country, there are few issues that create the same level of anxiety and stress as this one. And we know there's no simple answers, but if we can articulate the tensions that exist and identify relevant ethical principles, I think we can try and find a way forward together. So we do know that being a medical professional is being prepared to face some risks. This is a duty grounded in the need that society has for our specialized services, the social contract between medicine and society, and the notion that we entered into the profession willingly. We know historically this duty of care is being tested in times of pestilence and pandemic. So we know that physicians who left Europe in the time of the plague were both vilified for abandoning their patients, but also lauded for ensuring their special skills would be preserved for future patients. So essentially during our current pandemic, we're doing some similar types of calculations. So we know we're already taking important measures to minimize physician risks. So for example, most places are exempting high-risk physicians from frontline care, or we've modified resuscitative and procedural practices, as Kirsten referred to at the beginning. And many physicians are adopting additional decontam procedures after shifts because they want to avoid taking this home. And while these things all keep us safer, in essence, they also help justify the ongoing expectation that we still show up and still see patients. But this issue of shortages or lack of appropriate PPE really take these calculations to an entirely different level. These create this profound ethical tension in physicians between their desire to help their patients and support their colleagues, but also this need to stay safe themselves, to keep their loved ones safe, and to be available for future patients. So when PPE is available, clearly it's hard to argue that the duty to care still applies in any meaningful way. And yet this alone may not justify withdrawing care. Clearly our responsibilities to our patients, our colleagues, and our institutions create a complicated web of responsibilities. So this clearly places a heavy burden on institutions, governments to lead in this area, to do all they can to avoid shortages, but also to plan for when they may happen. We know lots of institutions have adopted or imposed equipment preserving practices. And while the motive is noble to preserve PPE for the future, it is feared that these practices like limiting masks, mandating reuse of equipment, just don't provide sufficient protection. And I know there's always debates about the specific evidence that supports or refutes a certain practice. But there's also the ethical question about who gets to decide something is safe enough, the institution or the individual. We know that institutions need to seek provider involvement and clearly have a responsibility to use the best evidence available. But I think physicians also need to appreciate the importance of rules that help minimize risks for as many as possible and still consider future needs. And we know that a number of hospitals and provinces have developed explicit plans for managing very significant PPE shortages or a complete lack. And most acknowledge that care would not be optimal, that providers would be exposed to increased risks. But in these plans, they can also outline all possible alternatives that could be utilized. I think most emergency physicians appreciate that current shortages are likely due to overwhelming need and not poor planning, and that their unique skills are desperately needed by their patients. And so I really argue that we should not judge doctors who ask to step away from the front line if they have some unique consideration or exceptional circumstance. But I think we do need to encourage solidarity and creativity as we work together to promote everyone's safety during this most difficult time. So there are a couple more issues that I just want to quickly touch on that are frequently raised in this discussion. I know we've talked a bit about that reciprocity principle. David just touched on it. And the argument is that if healthcare providers face greater risks, they should get preferential access to everything from testing or hospital beds or even ventilators. And I know there's a utilitarian argument that says providers can get back to work and ultimately promote better patient care down the road. But sometimes hear phrases like, we have to look after our own, or the system owes us for everything we've given it, and these are the justifications that are provided. I think we need to be a little careful about these arguments. They do have some kernel of truth, but we need to consider the impact these kinds of actions might have on our credibility in the community at large. And I think we need to be careful and maybe even resist using our privileged positions to jump queues or access scarce resources if that's at all possible. There are also troubling stories of providers who've been hoarding PPE or insist on using more PPE than is recommended. And while some of this may represent genuine confusion, the principles of solidarity and working together argue for physicians to act as role models within their departments rather than seeing themselves as exceptional. And the last thing I just want to quickly address about this topic is just to think about the way we communicate with the public about these issues. I really appreciate what Sean was saying about the need for advocacy, and we know many physicians are putting out messages that are passionate, that educate the public, and that mobilize resources. But I think there also may be messages out there that are creating anxiety, that are placing blame, or might be oversimplifying a complex problem. And so I think we just need to make sure that our messages to the public are finding that right balance. And so for the rest of the time that I have now, I'm just going to shift some focuses. And this is also another topic that was based on some feedback we got from physicians at large. We're just going to talk a little bit about goals of care discussions in the time of COVID. And there's so many great resources about this topic, and this is being posted on the COVID information page in CAEP under the literature section. So for my rest of my time here, I'm just going to talk about why it's so important we have these conversations now. We're going to look at a general approach to goals of care discussions, and then we'll talk about maybe some important elements that should be added if we're finding ourselves in a place where critical care capacity is overwhelmed and these triage policies are in play. So clearly, in a time when we're concerned there may not be sufficient critical care resources, our number one job has to be to identify those who have already said they don't want them and make sure we respect these wishes. We know that anywhere from 40 to 50% of the general population have some type of advanced directive, and this rate increases with advancing age and in those with serious disease. And yet many studies show it can be difficult to transmit those wishes to frontline providers in a timely manner. So we really need to work to support and encourage any efforts that identify patients who already have advanced directives, and then we'll make these more accessible to us. An important corollary to this is that many people who do not yet have advanced directives would be happy to make one, in which they even place limits on the type of care they request, if we simply give them some basic information about their own prognosis and discuss not just the benefits, but also the risks of resuscitative interventions. Many people vastly overestimate the potential benefits and are happy to forego this care when given accurate information. And just before I talk about the actual conversation, I want to let you know about some interesting work going on in the US right now. Some places are suggesting we should be asking patients about their willingness to forgo care in the event of shortages. So this is a sample form from Colorado I'm using with permission, which essentially asks patients the question, if we get to a point where there's not enough resources for everyone, would you be willing to give up your chance at a ventilator for someone else? Sure, there's some critics of this idea, including some questions about how we frame this for patients, how you record it, and how it might figure out how you might act on these wishes. But it's an important, interesting approach to consider. So for the goals of care discussion itself, I use the acronym PROPS, which is preparation, relevant wishes, our understanding, patient's goals, pair treatments with goals, and summarize. And we'll just quickly go through each of these. So before starting the actual discussion, we need to prepare. We need to determine if our patient has decision-making capacity and can articulate their own goals of care, or if a substitute decision maker should be identified. We also want to optimize conditions for success, sitting down with people, minimizing distractions, including others who the patient might want to include. And once that preparation has occurred, we then provide them with some basic information about why we think this is an important conversation to have and why it's happening now. The next important step is to elicit the patient's and family's understanding of their current condition and the decisions that need to be made. An important part of this conversation will be a specific ask about prior wishes. So I really like the phrase, many people have specific wishes about what they do or do not want to have happen in the event of a serious illness. Is this true for you? This phrase offers a good transition. It normalizes the conversation, allows patients and families to feel a little more in control, and can give us a really valuable starting point. After finding out what patient knows and if they have any relevant prior wishes, then we get to say our piece. We need to correct misconceptions, discuss their current clinical condition, identify a reasonable range of options, and then we can provide specific prognostic information for them, helping them to understand the history of their condition and how likely it is that any of the offered options can actually alter the natural history. The next step, and some of this will already have happened, is to explore the patient's goals and fears to see if there are specific trade-offs or priorities that that patient has. The physician should keep this part focused on goals and avoid specific treatments if possible. So then the penultimate step will be to match the treatments you can offer with the goals that have been articulated. You're the medical expert, but your patient is the expert regarding their values and goals. And so both of you clearly have something critical to contribute. In some cases, it may be very clear which goals can be achieved and how we can do so, and then we can offer clear recommendations. In other cases, there may be a number of reasonable possibilities the patient can choose from. And if there are no treatments that can achieve desired goals, then the patient needs to know that, and some different goals need to be negotiated. And then the final step is to clarify how this shared understanding will be recorded and acted on. Particularly when patients are ill or resuscitative interventions are being discussed, it's important to emphasize all the symptom-focused care that can be provided, rather than simply identifying what will not occur. Physicians should also be sensitive to the guilt and fear that families may feel when care is de-escalated or withheld, and provide appropriate support. The literature has lots of tips for how to manage these conversations, but I just want to highlight 3 of them. The first is that most physicians have a specific agenda or specific information in mind when they start these conversations, and they feel pressured to get that out as quickly as possible. But even in cases where an urgent decision needs to be made, it's always best to start by asking and listening. The second is to try not to respond to emotion with facts. An empathic response in the face of fear or anger offers a much greater chance of a positive outcome than statistics. And then the third is that even in a tragic case or with a distressed family, finding common goals allows for hope. Arguing about treatments leads to rigid or defined positions, but negotiating common goals, such as relieving suffering, can allow for engagement and agreement. This is my second last slide. So as the COVID pandemic continues to unfold, we may find ourselves in the uncomfortable position of having goals of care discussions in a situation where certain resources, such as ventilators or ICU beds, are no longer available. And as David discussed, many of your institutions are developing or already have guidelines for determining who does or does not get access to critical care capacity when it's exceeded. These documents should also contain a process to be followed, and you should always refer to your local guidelines first. We know that our core ethical values of honesty, transparency, respect for autonomy all argue for disclosing to patients and families when we're in these situations of scarcity and letting them know the role that this has played in our deliberations. So for the relevant patients, they should be informed that COVID-19 has impacted our ability to care for everyone, that all efforts have been made to access resources, that a vetted or widely accepted supported guideline has been used to determine who is likely to have the best outcome, and that certain treatments may not be available for them or often would not be available to them. They should be reassured that all other available and relevant treatments will still be offered. So that's the end of the medical ethics portion. And now I'll pass it on to Lori, who I think is going to talk further about PPE.
Thank you very much. I'm just waiting for my slides to come up, and I apologize because I'm a little Skype invalid, and I have to say next slide for each change. So I'll just wait for Jeff to pull them up. And obviously PPE is on everybody's minds these days. It's interesting that they've probably known about the possible shortage for quite some time, and it's always sad when the urgency becomes quite an emergency. I'm glad at least Ontario is able to help you up in Quebec, because you guys are obviously enduring the wave of the tsunami before everybody else in Canada. I'm sure the rest of us are not far behind, and hopefully this sort of rapid production efforts that are being made will kick in, and we'll actually not run out of PPE. So slideshow, or how does it work? Do you guys actually, should I start, or
Yeah,
I'm just.
Lori, sorry, I just turned my mic on. Do you see it now?
I see it, but it's not full screen. So should I just start, or you're controlling it?
Go ahead, please. Yeah.
Okay, yeah. Okay, so next slide. So this is just a sort of a curve that if you have the resources, and trust me, China has incredible resources. So when you look at the PPE that China is wearing, and when you look at their the Chinese guidebook, which by the way is an excellent resource, I think everybody should probably get their hands on it if they haven't already. Their PPE levels are much higher than ours, and when you look on social media, you see what they wear, and you know, at the beginning of this, when you're looking on social media and you're hearing about this and you're seeing that, you're expecting that that's what we're going to get. And then you find out what you're going to get is quite a bit lower, and it tends to cause a bit of sort of concern to wonder, why are our standards so much lower, or appear to be lower, and will they in fact protect us? So if you go down to the bottom of the curve, you'll see WHO is established what the minimum PPE is. And now that we're facing resource shortages globally, everybody who once they started maybe with very high levels of PPE in their initial plans are all dropping to the WHO level. So whatever you see on WHO, everybody will say that's the standard, because they really can't reach higher than that unless probably they're in China. Now, China, who got a lot of donations when they were actually running out, and they did run out in some locations, they did get donations internationally, and are probably, like, if you gave them 100 masks, let's say, they're giving you 1,000 back. So people who have donated to China, or people in countries in need, are certainly being supported by China. Their workforce is getting back to work, and because of their way in which they run things, they can do things for whatever reason much more efficiently, and they have really upped the production, and probably will be able to contribute to the world supply of masks, provided they themselves don't get a resurgence of any significant of course. If you go below the zero level, you get into DIY. Fortunately, because of the, or unfortunately, depending on how you look at it, the do-it-yourself PPE is actually starting to look promising. I hate to say that. It's gone from the bandana, I think at CDC recommended at one time, to some very good-looking masks and substitutes that may actually be fairly effective, especially if combined with a face shield, but we'll talk about that at the end. We like to think that's never going to happen, but I think the things that you never plan for are the things that do happen. So it might be something to think about, and again, we'll touch on that at the end. So next slide, please. So when you see, if you look on the left, that's still the PPE that China uses. So if you look at some of their videos, there's even more PPE under that. So they definitely have recovered. This is what they were using in Wuhan. In some of the smaller provinces, they did run out of N95s, and they did run out of PPE. And what they discovered actually was the face shield was probably one of the most important pieces of protective equipment. If you had a face shield, it more or less covered your entire face, your eyes, nose, and mouth, and you had your mask there, much of your neck. And when they did swabs, because they were concerned, they went through the worst impact of SARS in 2003, so they're very concerned about this virus. They swabbed staff who wore this PPE to try and get a sense of what their actual risk or exposure was. They found very little virus, if any, or like next to nothing under the face shield. So of all these pieces of equipment, if I had to pick one thing I would want now to really make sure that I don't run out, it is the face shield. Because even if you end up, and you won't end up with a bandana, I'm pretty sure about that, but if you did, if you at least have a face shield over it, very little is going to hit your face. So it is an exceptional, underestimated, undervalued sort of piece of equipment. It's turning out to be a very valuable piece. In the middle is what our current recommendation is, and the gown is a bit higher level, but it's basically a face shield. This is an N95, which is what you would only wear in aerosol generation. Initially at the outbreak, Ontario and BC were using N95s for everything and not the surgical mask. They've since, because of the shortage, downgraded to the surgical mask, but it's generally in combination with the face shield now because of the numbers in the community. And then the gown, you can see there's a lot of open, uncovered sort of space in the gown. If you were lucky enough, on the image on the right, you would have a hood. And if you added a hood to this combination for intubation or whatever, when we did something called glow germ tests, where we blew or sprayed fluorescent powder or liquid at the person intubating, or even afterwards, to see how they contaminated themselves doffing, the hood gave tremendous protection around the head and neck. And they came out around their head and neck and face with pretty well nothing on it. So it's an excellent form of protection. However, it's just not available. So we can want it, but we're not going to have it. But I think there are a few substitutes that we can do that can get us pretty close to that. So we go to the next slide, please. So everybody has gone to sort of PPE conservation mode, which is one mask or an N95 all day until wet or contaminated. This was done in SARS 2003. It was incredibly uncomfortable. In fact, they really just gave you a mask all day. And I think at some point we were actually wearing 2 masks because they thought more was better, which actually it wasn't, because you became hypoxic and hypercarbic. But if you can get away with this, it's definitely shown to stretch your reserve, and using the N95 only for aerosol generating procedures. If you are in that situation, probably the N95 is contaminated. I don't know. I think at that point I would probably not reuse it. I would toss that one. Face shield, goggles, and glasses are all important, but the combination of the 2 of those it tends to fog. Glasses do give you some protection. So if you wear them naturally, it's a reasonable form of protection under the face shield. The value of glasses themselves is we tend to touch our face something like 2,000 to 3,000 times a day. And it's this transfer of what might be on our hands, or if we rub our face and something's on our face and we transfer it to our eyes, nose, or mouth. That's the problem. But if you have glasses, you're going to touch the glasses first and think about it. So I personally wear glasses, always wear them under my face shield. And if you are worried that you are going to touch your eyes and you don't wear glasses and you want to wear something like that just so you aren't touching your eyes, just make sure you get a small pair that it's really just for that purpose of blocking you touching, as opposed to spray or anything like that, because the face shield will provide that. If you go with the big goggles, or those sort of vented glasses or big glasses under the face shield, you'll really fog. And if you have to choose, always choose the face shield. It's definitely superior. There is some talk about, can you clean these things? There are cleanable ones. You'll have to check with your IPAC. But it's interesting how IPAC suddenly becomes innovative and creative and finds ways to recycle things that they insisted be thrown out before. So there are ways to recycle what was considered to be disposable. And what you have to do is check with your IPAC to determine and make sure that whatever is being done is actually safe for you. Gloves come in 2 forms, extended and short. If you look on I don't know if you can see it that well, but on the picture on the left, his left hand, there's a gap between the gown and the glove. You have to watch for that. That has to do with actually this gown not being the best quality. You have to watch for gaps like that. If you really have no choices, it just means when you wash your hands, you actually do your wrists and maybe your forearms. And so that's not a big deal. It's just something to be aware of, that these gaps can occur. You can use extended nitriles or surgical gloves, which probably shouldn't be in short supply if you need to extend it to capture the cuff of the gown. Like I said, reuse, clean, and sterilization methods are all being looked at. Out of Stanford, there's a recipe, if you will, for baking your N95. I think it's 30 minutes at 150 degrees, but it's online. And apparently Stanford and scientists have said it doesn't degrade the mask, the N95. It does kill the virus or whatever else is on it. And what it isn't clear, though, is how many times you can do that before it does degrade, but it seems like you can do it at least once. Next slide, please. So I think everybody knows Dr. Wen Liang. He's the ophthalmologist in China who detected this because his patients were coming in sick, and he subsequently died from it. What he does have is whatever is coming to everywhere, which is high flow nasal cannula. This is when you see things that say high flow nasal cannula or high flow nasal prongs, you really need to make sure they're not talking about 15 liters per minute or something like that. This is like 30 to 60 liters per minute. It's under a mask, and almost for sure, like there are people who are saying this is not aerosol generating. I think that is absolutely incorrect. But what we don't know is what the threat is to us. I have talked to people in China about how did they manage these patients, and they wore the PPE that I showed you on the previous slide. They had 4-hour shifts. At some point they got down to 4-hour shifts. Only initially they didn't, because they were just way overboard and burdened, and you heard the stories of them sort of wearing diapers and things like that. But eventually they got down to 4-hour shifts. They had very limited time in contact with the patient, so they actually managed to control their exposure time and do something about trying to control the environment. So what we were trying to figure out and haven't quite figured out is why he has what looks to be an oxygen mask over top of that. So whether that was some form of containment of the aerosols. So there is some research going on at Sick Kids and myself, and we're trying to figure out just how we can better contain those aerosols, because almost certainly this will be the bridge or the option for people who don't get a vent for as long as we actually have those resources too. So your risk is related to the viral load. That's always the sickest patient, generally speaking, has a higher viral load. How long you're near them, the proximity to them. So if you are within a meter, that's considered the danger zone, and the type of exposure. And obviously if they they themselves generate aerosols. They keep saying that cough is not aerosol generating. It absolutely is. Aerosol generating is one of the number one reasons we paralyze people doing the protected code blue. It was because they were coughing before we intubated them that that's where that problem came from. So you have to think that if you're close to these people, if they're coughing, you really want to spend as little time as you can and try to keep your distance. And then we'll talk about the barriers and the ways in which to do that. So the types of exposure. So next slide, please. So interesting enough, it took them a long time to find the first case in Italy. They ultimately traced it back to a young, healthy guy who was out running with the soccer team. He went to a few emergencies, and they would have done what any one of us would have done, which is, you got some kind of viral disease, just go home, take some ibuprofen or whatever. So he made a number of visits. He did spend time with friends, and that's all it took. That's not unlike other places. I'm sure in Toronto in 2003, it was one person too as well. So this has obviously led to a much more worrisome thing because of being able to transmit the disease when you're asymptomatic. So if you have it in your community, it's without a doubt, you should be wearing at least a surgical mask all the time in your ED. You will never know for sure who is and who isn't. And you may yourself be an asymptomatic carrier without knowing it. And at least that prevents the transmission from you to others as well. So I think more or less in Toronto we're that way. I'm sure Montreal's that way. Probably anybody who's in Vancouver, anybody who's sort of got for sure community transmission, or if your numbers start to come up, it's just a matter of time. Once you get your first positive, they figure there's actually probably about 100 other people out there with it. So asymptomatic carriers and the unrecognized COVID is probably the number one way in which these are spread and all these outbreaks are actually started. Yeah, so that's what we're trying to worry about now. So next slide, please. So what is an aerosol generating procedure? So this is probably the most quoted study. It's sort of a Cochrane style study where they did a meta-analysis of, I think it's at least 5 or more, maybe 10 studies, and they came up with, there was no doubt that they felt this was associated with it. And then there was these are not considered significant. So without a doubt, intubation is considered the highest risk. What I'm not sure, because that really comes out of SARS literature, is in fact, once we started paralyzing them, was that actually the case? Because what we were not doing at that time, we were intubating late, so they had high viral loads, they were spraying in the environment, and we were tending not to paralyze because we were worried about them getting hypoxic. And so there was a lot of process that's not related to PPE that probably led to the spread. So it's definitely still across the board the highest risk, but there's a lot of measures that are not related to PPE that have probably lowered that risk. Non-invasive intermittent ventilation or non-invasive sort of ventilation. Well, when Optiflow and Airvo come in, what are we going to do about that? Because it's still listed as high risk. Other people are saying that's not the case. BVM is a high risk, but if you have a 2-person BVM process in place, a tight seal should control, but really that person has to manage that seal, and they have to think of as it spraying and posing a threat to everybody in the room if they don't manage it. Tracheostomy, that's probably not that commonly done. The interesting thing is that CPR is not considered aerosol generating. They also, in there, they actually say high flow oxygen. I think at that time, which was 2012, they may have just been talking about nasal cannula, but I'm not entirely sure. Defibrillation and a few other things. So next slide, please. So I'm not sure how well you can see this slide, but always read the fine print. If you look at all the studies, the quality, it's every single one is very low. And the problem with this is they talked about the procedures, but the PPE worn by the people who were, say, contracted disease is all over the place, from none to some to all over the place. So the quality of this was literally terrible. And the conclusion, which isn't quoted because is that the lead author on this said, really the evidence was really poor. Even though we have these sort of lists of things, it should be used for theoretical discussion and not clinical decision. And so my take-home point on that is read the fine print, and always take what you hear and think about it for yourself. Does that make sense? I want to be reassured, but maybe I want to be reassured by better evidence. And the transmission to healthcare providers, there is literally little or no tracking of the PPE that's worn, and the duration they're exposed and all these other types of variables. So I don't know what we've been doing for 17 years. We should have been studying this. But however, what I don't want to see is us become guinea pigs for this. And so if you have doubt, make sure that you take precautions and learn more about this yourself. So next slide, please. So my rule of thumb is, okay, if it can come out of that nose or mouth, no matter how it comes out, I want to make sure that I use something to protect myself. So obviously if there are vital signs absent, there's nothing coming out of that mouth. When you do CPR, maybe something is coming out of that mouth. You should, and I have a very simple thing, is that go back to ABC, secure that area or cover it or protect it, so that when you start to do whatever else you do with resuscitation or whatever, you've sealed that orifice of virus that could come out in various ways, maybe not 3 feet away or 6 feet away, but it could certainly come out. And even if it just comes onto the bed or in the face and you're going to be manipulating that area later, you should take care to be very mindful of that and secure that area or cover it or protect it in order to protect everybody else in the room with you. Use distance barriers, and then finally PPE to protect yourself. Negative pressure rooms are not available. Remember this, for the most part, this is considered, well, not the most part, this is considered a droplet spread and not in need of negative pressure. That's an added plus, I guess, if you want to say it. If you do aerosol generation, you can get droplet nuclei small enough that they will be suspended in the air. And the idea is that negative pressure will keep it in the room and not have it go outside. Next slide, please. So defenses, so non-PPE defenses, the patient's always got a mask. And if they have nasal prongs, like this patient is actually one of our emerge docs, he's not a patient, but nasal prongs, over the nasal prongs. If you have a mask, if you can get these masks, I don't know what you can get now. This is called, the middle one is a hyox mask. So when you exhale, the exhalation is filtered, has a viral filter. And the one on the right is called helmet CPAP. I think the only place it's available in is Italy. They're not allowed to export it, obviously, at this time. But you would think that somebody could kind of come up with some kind of MacGyver version like this. Even if we go to Airvo or Optiflow, might be able to trap the any kind of aerosol. So it's pretty interesting stuff. Walls, make sure you communicate with phones. Everybody has a cell phone. Make sure they bring in their chargers. Then they understand that's how they're going to communicate with their family or you. And those kinds of things provide you risk. The critical space, if you're within a meter of that patient, or specifically their heads or their airway, that's where you're going to start to get higher viral load. If they cough, they may get a few aerosols in that, and that puts you at high risk. Next slide, please. So you hear about the cardiac box with the stabbing and shooting and stuff like that. Your main place of protection is the respiratory box, so eyes, nose, and mouth. The number one things that we really need is a mask or an N95. And once you actually have the face shield on, that really elevates the protection level of the surgical mask. And just briefly, the surgical mask, by the way, and I'm sure everybody knows this, was never made to protect us. It was made to protect others from us. So it's great at capturing any kind of infection we may spread. That's a good part of it. The way it does protect us really is we tend to touch our face so often that because it's over our nose and mouth, we're not going to be able to transfer things to that area. And that is the number way of protecting it. When you get to an N95, it is fitted. It's, it filters out down to 0.3 microns. And so there should be almost no aerosols or droplet nuclei that get that small. So it should be able to keep out anything from an aerosol generated procedure. So that's why we really need to reserve the N95 for that purpose. Next slide, please. So just to reiterate, if you can find a way to clean that face shield, you should. I know that one of our orange docs up in Timmins was running a COVID clinic. He had only he used 2 shields the whole time. He said you just clean them with cavi wipes. I don't know if that's good, bad, or otherwise, but if you're down to nothing, maybe you need to think about if that's possible and talk it over with your IPAC. Next slide, please. So I did a PPE talk for emergency medicine cases with Anton Hellman, and one of the strangest things that caused controversy was the gown recommendations. The gowns go up and down like everything else, and so what we had done at our hospital was say if you could hold it up and it's the see-through gown, that's an isolation gown. So they removed them from our emergency, but it turns out most people that's all that they have. And I was completely unaware of that. I thought all hospitals would have a choice. So I went to WHO, which is also changing their recommendations relatively frequently. Before it's just gown, but nothing specific. But now they say like it can be a level 1 gown, but if you're going to do, which has no fluid resistance. So if you're going to do aerosol generation, they say add an apron. I'm not entirely sure what an apron would add to your protection, but maybe I'd have to think that one through. I can't fully get it. Probably one of the most useful gowns is the washable yellow level 2. If you don't have them, don't worry about it. Just what I would suggest that level 2 or the combination of 1 plus something, if you're going to do aerosol generation, is what you need. But just check the tags on these things. They may there is a level 2 yellow gown that looks exactly like the isolation gown, except that I think that it has cuffs. So just check these things and make sure. If you don't have them, maybe you can ask your IPAC or somebody like, could I get more? Because of the level 1 gown suddenly causing a bit of anxiety around people, I did talk, I have some backroom connections with the military and defense scientists to ask them just how important is this gown? Like, should we be worried if it's not the best? It's what it is protecting your greens underneath. And I guess the bottom line with this, if you're wearing something porous, at the end of your shift, well, you're not taking your greens home anyways, and you should certainly be showering either at work, although if everybody there is showering because they were trying to get rid of coronavirus on their body, you might not want to shower at work, but at least wear clean clothing home and shower at home before you sort of meet with the rest of your family if you aren't isolating. Okay, and the gowns, take a look at those. They have to cover your back. Some are actually aprons with sleeves. And because there's poor neck protection, you should try to tie them higher to give yourself more neck protection. Next slide, please. So head and neck cover, not currently recommended. You see the fluorescent sort of stuff on the left there. That's our glow germ. I blow it on them. I don't blow on anybody now, but like 2 months ago when I was training people in the Protect Code Blue, we would blow a little bit on them before that they would doff, and there was clearly contamination in the neck. Hoods, we can't get. Maybe some people can. If they can, I would say that you should use it if you are for intubation, not just for any kind of patient. But and they don't recommend hair kind of stuff like bouffants, although apparently there's a hospital policy that has to be tied up and back. But I just think it's crazy not to put your hair under cover. So next slide. So bouffants definitely do give you some coverage. They cover at least your ears and your hair. We did find with the glow germ sort of stuff, testing, because some people chose a bouffant, some didn't, then in fact it did give significant coverage on the sides of the face, and you can see where it would cover more than I actually expected. I thought it would just go right through that cap, but it didn't. So it's very inexpensive, easily available, and easy to doff safely. So I would definitely recommend it. Next slide. So I did look, because again, I was concerned about this lack of a hood And so I went to look in the literature in the Middle East to see what the people doing MERS were. I set out some email and talked to a few people there. The interesting thing that they have, which I don't think anybody has, is after they doff, and they had a higher level of PPE, they did have hoods, but after they doff, they sanitized or washed their face and neck with soap and water. And I thought that was actually a good idea, because clearly we are vulnerable in the neck, and we could easily make that part of it. We wash our hands, repeatedly and stuff like that. But if you've just intubated and you're worried about or performed an aerosol generation type of procedure, I think you should add this to your regimen of preparations in staying safe. Okay, next slide, please. So there was a number of questions. So I'll just try to read them quickly. If we ran out of the option to purchase certain supplies, like from countries like China, I will tell you that because we did donate some supplies to China, they've repaid tremendously in a multiple. So if we gave them one, they gave us 10 back. They will probably, they are focusing their attention on Europe right now, because especially Italy, and they've sent a team and supplies to Italy to try and help them. Italy, and I actually don't know about Spain, but I wouldn't be surprised. I sit in meetings with the Chinese. I found them to be incredibly wanting to help, do anything, share information, ideas, anything. And I'm supremely impressed with their efforts to want to help globally with this situation. So I think if we could buy from them, we would be able to. And if they, or if they could have the resources to donate, they would. Other suppliers, U.S. will probably not. So all domestic supplies are basically now sort of frozen. But there is a light on the horizon. I'll talk to you in a second. Waiting for domestic supplies. So actually, would healthcare workers be able to wait for that long? Well, next slide, please. So I think you've seen in the news stories almost daily about the federal government working to get companies to make things and companies stepping up. So Bauer making face shields as an example. Now there are a number of contracts that have been awarded for making surgical masks and N95, and the usual process that would take 3 to 6 months for approval is now been brought down to 7 to 10 days. So, and NIOSH apparently is involved in making sure that they just don't make some sort of counterfeit stuff, that there's actually a standard that will be maintained. When I hear that somebody's going to run out of supplies in 3 or 4 days, that's alarming. But I didn't think we would get that close. But there is a light on the horizon. Hopefully, if we do run out, we won't run out for long, and hopefully we won't run out. And I will tell you there's some promising do-it-yourself masks. One is the Olsen mask. You can look it up. And I think it's a little tedious to make, but I think it actually looks good, and I can report back next time. I'll make one and see what it's like. Next question. So Canada lacks a universal regard to PPE used in the emergency department. Actually, that's not true. Everybody's fallen to the same level, which is the WHO level. Where is different is when they are activating the all-day PPE shift. So many places are sort of, because they don't have a lot of cases in their community, they're saying just wear it if they have symptoms. But if you do have cases in your community, you're probably going to actually save PPE by just wearing one surgical mask the whole day, or for as long as it's not contaminated and not wet. And I think it's probably a safer process and will save PPE, rather than, okay, that one's got ILI, I'll wear one mask for that one. Oh, then I see a bunch of chest pains, but I don't see anybody else. And then I go see another one. You probably consume more resources that way. So people who have been having that problem, we've been hearing that, you should just make the argument that if I wear that mask for as long as possible during a shift, changing it infrequently, that'll actually save PPE, because I think that they're trying to save PPE, and they need to have that honest conversation about when that PPE is going to run out and what their burn rate is. And I think that's something we should have, again, been looking at a little more aggressive on. Next question. I think this is sort of the same idea, that there's been a suggestion the burden of disease increases, probably wearing PPE for all patients. Yes, you should, but already running out of short supplies. Does it make sense to wear the same potentially contaminated mask all day? Well, if your mask is under a shield, it's probably not contaminated at all. If you have a shield, in fact, many of the hospitals, although not all of them in Toronto, are wearing surgical masks with the face shield over top, because it does protected from getting contaminated. The only thing that does happen is that the humidity might go up in that sort of circumstances, and your mask might get wet. And if it starts to get wet, then you really should replace it. If you are wearing a PPE all shift, one mask, I think we actually have to sign for them now, but it is definitely going to conserve PPE, because I know at the beginning of this, I was probably going through like 10 masks a shift, and now you might use 1 or 2. And oh yeah, and if you do think it's contaminated, not think it's contaminated, change it. Next slide, please. The hair protection, I think we talked about it. I'm a fan of it. Your IPAC and those guys may say, well, you might contaminate yourself doffing. I watched about 30 people doff, and they had maybe one tiny speck of the glow germ on them. They washed it off as they should before they took their mask off, and there was never a problem. So I think it's safe. I think it adds benefit. It's cheap, and you won't run out of it. Next slide, please. Should goggles be worn during a high-risk procedure like intubation? Well, you can make your choice. It's you need some eye protection for sure, but I think face shields are better. So if you have that, I would use that. If you don't, then goggles or those sort of industrial glasses are an acceptable option, but face shield is definitely superior. So I would try to get that if you can. I must admit, I went to big box hardware and I got one, a heavier duty one that I knew that I could clean from Home Depot. I don't think there's any left, but at least I know I'll have a face shield that I can hopefully get through this whole pandemic with. Next slide, please. I think I actually accidentally picked up a procedure question. Is defibrillation considered aerosol generating? No, but because of everything else you're doing, CPR, bagging, whatever, you bet I still recommend go back to ABCs for this period of time we're in a pandemic. Secure that airway, whether you cover it, you put a mask over it, you intubate, protect. It's like a form of protection for the team. Secure it, and then do everything else that you need to. You're never going in there by yourself anyway, so the fact that one person is dedicated to that takes 2 seconds, and the next person starts the chest compressions. Next slide, please. So this is an interesting question, and I think this is the kind of thing that creates a little bit of tension between physicians, nurses, and IPAC people when you feel you need some equipment and they say you don't. So my hospital's not allowing us to wear waterproof gowns for intubations. You don't need waterproof, and I'm pretty comfortable making that recommendation. But I do think you need at least a level 2, so some fluid resistant gown. So at least go for that. If you're down at the WHO level, they say add an apron, but I think the only apron you would have is the kind of the blue plastic Ebola gown, which is like sleeves with an apron. If you add that, you're actually at waterproof. Can you please put a position statement saying what PPE is required for intubation? Well, it's well known, and there is no position statement needed because it's the WHO recommendation. So N95 is the only piece of equipment that you upgrade to from the other PPE. It's the only piece of equipment they insist you must have for aerosol generating, and intubation is considered an aerosol generating procedure. So N95, eye protection, my preference is face shield. A gown is level 1. I recommend level 2 if you can get it, or level 1 plus something, and gloves. So there's no need for a position statement. It's very clear. As for what you would wear in a fever clinic, all you would just literally do is downgrade to a surgical mask, and everything else is the same. So next question, please. So why are we not securing the half-space respirators with appropriate filters? Actually, that was a brilliant question. And probably everybody who's done any kind of home renovations may actually have this, and they would work. You just have to have the filters. These are like N95 up, and would be perfect protection. They are cleanable, reusable, and it's, because it's, I gave the helmeted guy because that's where we see it. We don't always think laterally about where else we could get these resources. But the shelves have been cleared. I'm not sure whether we can get them, but you know what? You might have them in your garage. So go take a look, and they would work. You would have to just make sure you have some filters. But if you run out, then probably you can put some kind of filtering paper or something like that, secure it, provided it's breathable, and it would be usable. I found one in our basement. My husband was using it for, I don't know what, drywall dust or something. And I'm looking at it, it's actually way more comfortable than an N95, and I felt a lot more secure in it. So it's an interesting thought. We should have thought about it sooner. Next slide, please. And the national standard for air generating procedures, we actually talked about that before. Level 2 or level 1 plus an apron. Everything else is the same in this, the N95. And next question. And this is my question, actually. Is this an aerosol generating procedure? I feel that it is. There's a lot of people saying, we're just going to do it, which I think is a bit of a cowboy kind of attitude. I think we should do it, but we should also figure out how much of a risk is it to us, and how can we contain those aerosols? And we're going to have to do that fast, because this is going to be a definitive and very widely used form of therapy for these guys. And it may turn out to be, actually, since so many people actually who end up intubated don't survive, this is the middle group that has the bigger numbers and that may very much benefit from this plus proning. And so we really need to get on this fast. So this is a hot button kind of thing. They're using it in Italy, but I have a friend who's working in the ICU there. She's PGY5 in anesthesia, and the residents there are running the critical care units. And she says they're putting them on all the time, and she doesn't actually, they're just putting a mask over it. But she says their staff is getting sick all the time too as well. So it's hard to know when the virus is everywhere, where exactly you're catching it. I think we can safely say that there's certain things that we do that increase that risk. This may be one of them. We should think about how we can reduce it, rather than just say, yes, we got to do it. We have to do it, but let's try to step back and think about how we can trap those aerosols. And next slide, please. And I think that's one way. We should go look at the NICU guys and how they do things, because I think they've been thinking about this for years on how to contain things. And that's it.
Looks like I'm up next, I think.
Yeah, can you see your slides there? Okay, Dr.
Yeah, I can.
Okay.
That's great. Thanks very much. I'm Tom Miller, emergency physician at Peterborough Regional Health Centre. Peterborough's just northeast of Toronto, about an hour and 20 minutes. We're a 450-bed hospital, and we get about 90,000 ER visits per year at our single site. Thanks very much, Kristen and Dan Kollick, for inviting me to speak about this. I've been put in charge of liaising with our long-term care physicians as well as our community physicians, and our goal really is to try and minimize the transfer of patients from long-term care facilities and from the community to the emergency department. So could I have the next slide, please? Great, thanks. And so I just want to emphasize the most important thing is really good communication between the emergency department and the long-term care facilities. That's key to establishing sound planning and appropriate care. So what we've done is our incident management team has a long-term care lead, Brenda Weir, and she's was initially involved in setting up a teleconference between the directors of care at long-term care facilities and the medical directors. And then I followed up with that and contacted medical directors individually as well as long-term care directors to talk about how it is that we can try and maximize keeping patients in the long-term care facilities, supporting those physicians and nurses in those facilities, as well as in the community. So we're also talking about family health teams in Ontario, the Ontario model for primary care. What we have noticed is that there are patients in long-term care facilities. Most of them have advance directives or have DNR orders, but some of them don't have full advance directives. And so what one of the medical directors did was put out a letter to the long-term care physicians and physicians in the community to make sure that they revisit with families those directives and have those serious conversations that were talked about earlier in the presentation tonight about goals of care and realistic care, especially in a situation if we are overwhelmed with both volume and acuity of patients in the emergency department and in the ICU, and where ventilators become a resource issue. If I could have the next slide, please. So just in relation to that, again, organizing that conference call and making sure that you've got a lead in the emergency department and leads in the community who are involved in this. Next slide, please. And so, as I mentioned earlier, a number one key thing is the revisiting the advanced directives. And it's important, I think, as we move through this pandemic a week ago or even 2 weeks ago, I think physicians were thinking about this, but as we see what's happening now in New York and in other places, not just Italy and Spain, people are realizing that this has the potential to hit us very hard, and we need to know what the people's care plans are. As many of you have seen in the Globe and Mail recently, a long-term care facility not very far from here, about 40 minutes, in Bobcaygeon has already had 12 deaths in their facility. Now, from what I understand, those patients all died at the long-term care facility, so they weren't transferred to the hospital, but that issue did come up. Could I have the next slide, please? So the other thing that I really want to stress is, and I'm sure we've all experienced this, and it's no fault of our long-term care physicians who are on call. I know that in our community, we have about 1,200 patients in long-term care beds in 8 facilities, and on the weekends and in the evenings, there's often just one physician on call for basically 1,200 very vulnerable patients in the community. So what we've really stressed with our long-term care colleagues as well as our community family physicians is that there be an MD to MD consultation or transfer of care. So just walking through the scenario, if you had an 85-year-old patient in a long-term care facility with what you might think is COVID and perhaps also pneumonia, but has multiple comorbidities such as cardiovascular disease, diabetes, dementia, do they really want to transfer that patient to the emergency department with realistic goals of care? And I will touch on this in the next couple of slides in terms of testing, lab tests, as well as x-rays. But it's having that conversation with that physician if they really need to transfer that patient. And what my long-term care physician colleagues have told me is that often they may not want to transfer that patient, but families are insisting that the patient be transferred because making the decision to keep the patient at the long-term care facility and making that final decision to potentially palliate a loved one, often for a lot of families, is a difficult one. So we can actually provide a bit of a second opinion to the long-term care doctors and the community doctors, and then they can go back to those families and highlight to those families the situation that we're in the emergency department, and in some cases actually maybe use us as a second opinion to say, look, they've spoken with the emergency physician. They don't think transfer of care is best value for your loved one, and the more humane care would be to have it done at the long-term care facility. So if I could have the next slide, please. So one of the things that we looked at was lab tests as well as x-rays, and then IV antibiotics and IV fluids, and I'll address each one on each slide. So lab tests, what we were hoping was that right now the model is that usually a private company, like in Ontario, it's Life Labs or Dynacare, go to the long-term care facility, draw the blood work, and then take that to their lab to be analyzed. I suspect this isn't quite the same problem in the GTA or in Ottawa, but in Peterborough, the closest labs are either Toronto or Belleville. So it's usually about 2 hours to actually physically take the sample down. And of course, they batch them. So, if you're a long-term care physician, you have a patient at 4 o'clock in the afternoon that you want to get some blood work on, you may not get that result back until midnight. So what we are thinking is there a faster way to get quicker turnaround times on blood work? We tried to look at having it so that the Life Labs or DynaCare could go into the long-term care facility, draw the blood, and then have it brought to our hospital to have it analyzed. In this case, it looks like that process is not going to work out for reasons related to our lab and how it's set up and a concern about capacity. But I think in other communities, this may be something to potentially look at. And I know that I've had conversations and good communication with the medical director of Life Labs, and he's very supportive of this. So that's something to consider. Next slide, please. So X-rays, 2 parts to the X-ray piece here. One is to maximize the use of portable X-ray service, and I'm sure this exists in most larger communities. I'm not sure, say, Sean, what it's like up in Kenora. But I know in Peterborough we use STL Diagnostics, and they certainly, I've had conversation with the president of that company, and they're very keen on doing everything they can to provide portable X-ray service to long-term care facilities or in the community. There was a concern about PPE. They reassure me that all of their techs, as well as their equipment, the techs wear PPE, the equipment is sterilized. So hopefully there's not a concern about one tech with a portable X-ray machine going from facility to facility. But the use of portable X-ray is an excellent resource for physicians, and I believe those services are going to try and get that in an urgent manner. So one example, and we actually had a case of this the other day, where a patient fell late in the evening, injured her knee in a long-term care facility, and that person was transferred to the emergency department for a knee X-ray. That obviously could have been an avoided X-ray. That patient could have been given pain medication overnight, and a portable X-ray could have been done the next day to rule out a fracture. So I think we're looking at trying to do the same for hips and even wrists. I think the numbers are not really, really high, but again, if we get into a situation where any avoidance of a transfer would be important, because that transfer not only ties up either the transport service or an EMS service, puts the patient at risk, and is a use of resources that is preventable. The other piece is the chest X-ray as well. And again, we've highlighted with our long-term care colleagues and family medicine physicians that the use of a chest X-ray, especially in a COVID-suspected patient, is not as valuable as we might think, and that the patient should be primarily treated on a clinical basis. But if there is a concern that they really do want to get the chest X-ray, they've spoken with us, then we have set up a process for that patient to be transferred to the emergency department. Diagnostic imaging was hoping that they wouldn't come all the way into the emergency department through the corridor and down to diagnostic imaging area, but that we would have something set up in the emergency department near the entrance. So we have been able to organize something like that and developed a protocol for that. So I'll just, if I could have the next slide, please. So this is a little bit of a busy slide. Hopefully it'll be available to people, and please use it in your own facility if it's helpful. If you just start at the top and walk down to the second box, does this patient need a chest X-ray? And then if you move to the right, if the answer is no, then there's a whole piece in there about how to direct the physician for the care of the patient. If the answer is yes, then and if it's not after 10 o'clock at night, then what we're recommending to the primary care physician as well as the long-term care physician to follow a process where they definitely contact us, and then they contact the probably the triage nurse to direct them to where they go near the entrance of the emergency department. Diagnostic imaging will be contacted. They'll bring down a portable X-ray machine, and that person's X-ray will be done. The result of that will be read very quickly by the radiologist. That result will be called to the long-term care physician or the community physician, and then a disposition will be decided at that point. So again, if we walk through the scenario, they want to rule out a fractured hip. If the X-ray is negative, then the patient goes straight back to the long-term care facility. The emergency physician doesn't even see the patient. But if there was a concern, like a fractured hip, and they needed to come to see us for admission, or if there was, say, a critical result like a pneumothorax, then the emergency physician would get involved. So that algorithm just helps people to walk through that process. If I could have the next slide, please. So the other piece to this is maximizing the use of home care services for IV fluids as well as IV antibiotics. And there's still the practice, I know, in our department where patients get sent in from the community or from long-term care facilities for their first dose IV antibiotic in case they get a allergic reaction or anaphylactic reaction. I did a very quick lit search on this. It's not comprehensive, but there was one good paper published, and it showed that for cephalosporins, the anaphylaxis rate was 0.6 per 100,000 doses of cephalosporin. So at least in that case, the risk is minuscule. So we had actually had a teleconference today, and home care was on that, and they're going to review their policy because really we shouldn't be seeing any patients coming in for first dose antibiotics. I know that in a lot of long-term care facilities now, they're actually providing IM ceftriaxone and avoiding the use of IV. So that's one possible solution to that as well. And again, just maximizing the use of home care services, say for IV fluids or other service. One issue, though, that's come up, and it's come up again in the previous talks, is a PPE. Home care seems to be pretty low on the list of people being provided PPE if there's a shortage. So ironically, they may not be able to provide home care service in the community or at long-term care facilities, and then those patients would end up potentially coming to us, unfortunately. So just in summary, the main thing is MD to MD communication. Make sure you have set up in your community a link between your emergency department and those physicians and the directors of care in those communities. They are, as we know, taking the brunt of this right now, and any support that we can give them is paramount, but also making sure that we don't get any unnecessary transfers and that goals of care are realistic. This also applies to the family health teams and physicians in the community with their patients. And the one big area that is a bit uncovered is retirement homes. As we know, retirement homes have different levels of care. And so in some retirement homes, they actually have essentially long-term care, high care units. These are all, I don't want to quite say a mishmash of facilities, but there's no full coordination amongst retirement homes that allows, I think, for comprehensive discussion and planning. And that's something I think if you can work on that in your community to get everybody on board, all the better. But those areas, those facilities have some of our more vulnerable patients as well. So I'll leave it at that. And thank you very much again for the opportunity to present this, and good luck to everybody.
Thank you so much. And I'd just like to wrap up by saying thank you very much to all our speakers. The last presentation is exceptionally relevant for us in Quebec. In Montreal, we have 500 long-term care facilities with COVID infections and outbreaks. It's scary times. So again, fascinating content tonight, and thank you to all the experts and to all of those out there in Canada and beyond who've tuned in to listen to us. We hope that you'll come back next week and that you'll submit your interests in terms of topics and speakers and questions to us through the CAEP website and Christina Bova. So thank you again, and stay safe, stay healthy, take care. Good night.